So yeah, once again, good evening, everyone. Thanks for joining us. Today we have, I think, 9 cases with one follow-up. We'll go ahead with our first case. And the chat is open, so you can put in your comments and suggestions for each case whenever appropriate. Thank you. And Geeta, you can take over.
Yes, sir. This child was a 2-month-old female child, 2.78 kg at birth. And also, like, there was a hypoglycemia on day 1. This was managed with feeding and all discharge. Around 1, and there were no issues later on. Around 1 month of life, had a breathing difficulty and dull activity, and they have observed cyanosis of the limbs also and lips, for which the child was hospitalized. So cardiac workup was done, and it was showing cyanotic heart disease, and also had sepsis, and recovered from that in 2 to 3 days, then shifted to ward, then noticed to have seizures in the form of staring and tonic posturing, and later on had encephalopathy, breathing issues requiring ventilatory support for 4 days. So in CT was done on the day 1 of the neurological illness and MRI on day 2. This child was treated with IVIG for sepsis and presently like admitted at the cardiac center, like further like for the management and all. Now presently the child is discharged from there, not on any oxygen support. So here we want to know like there are fluoric changes on the MRI, and we want to know about the pattern recognition in the MRIs.
Okay.
And also,
so the labs were done after the MRI or before the MRI?
Labs was done, like few were done before MRI and few were done after MRIs.
Okay, we'll have a look at the MR first and maybe you can get
yes.
That. CT, I have not put it up because MR changes are pretty more suggestive. And so they have diffusion and ADC sequences over there, and you can appreciate extensive cytoptic injury with a predominant centripetal pattern going from the center to the periphery, involving the white matter structures, predominantly the white matter structures, but also the deep brain nuclei, that is the basal ganglia and the thalamus, the corpus callosum over there. And on the ADC sequences, you can see that the basal ganglia thalamus changes and the periventricular deep white matter demonstrate low signal changes on the ADC. The ventral brainstem also demonstrates some areas of restricted diffusion. On the T2 weighted sequences, again, corresponding edematous changes in the cerebral hemispheres, diffuse extensive involvement with some areas of linear hypointensities which correspond to the SWI changes below. So the SWI changes, you have this typical fan-like or radiating pattern of areas of blooming going from the center to the periphery along the deep medullary veins and predominantly in the periventricular region. The T1 weighted sequences demonstrate some areas of hemorrhage and ischemia over there, predominantly in the periventricular and subcortical regions. Venography was done, and these are MIP images. The source images do not demonstrate any thrombosis of the main pleural sinuses or the deep venous system. Based on the imaging findings, the pattern was correlating with the deep venous system. That is, you can see on the top panel over there on the left, the territory of the deep venous system. And the possible etiologies for that are the coagulation states. It could be a hypercoagulable state, a vascular wall injury, or circulatory stasis. Different factors predisposed to these conditions, such as thrombophilias, infections, inflammatory disorders, cardiac abnormalities. If there is family history, though not so florid, COL4A1 and COL4A2 and the junction adenosine JAM3 mutations can demonstrate these medullary vein thrombosis. This on the right is an example actually from Rainbow. Dr. Lokesh had published this in 2014-15. You have this intraparenchymal hemorrhage with the deep medullary vein pattern injury better demonstrated on the parietal sequences over there in a typical fan-like pattern. Without the medullary vein thrombosis, but the extensive periventricular predominant injury can be seen in viral neonatal viral infections. Paricovirus is a common differential with other viral infections such as rotavirus and influenza can also demonstrate these changes. So imaging-wise, deep medullary vein thrombosis with possible infection over there are the differential we thought of. And going back to the labs, Geeta.
Yeah, there was a elevated CRP initially, and also after the treatment, like even repeat was like when the child was encephalopathic, that time repeat CRP was also elevated. And 2D echo wise, there was tetralogy of Fallot with the VSD, and small PDA was there. And otherwise, CSF was normal, that was normal coagulation profile, and LFTs were also normal. So here we have a question for the pattern recognition and also to other neurologists here, like how to do the counseling and the long-term prognosis, how to like to know based on the imaging and all. So that is what we want to know, sir, to counsel the family.
Before we go to the panel, this is a paper from AJNR. I personally don't use the scoring system, but I'd like to know if others use this scoring system for prognosis. They score it from 0 to 102, so the variables are pretty wide off. So I don't know if especially Dr. Mankal uses these scoring systems for prognosis, or are there any other markers for the neurologists for yeah, as you said, counseling and prognosis of the child.
No, I think the scoring system is very tedious if you were to use it. And more importantly, if you look at the initial scan that you showed, there was a lot of diffuse change there. I mean, this would be a very high score without even wanting to score it.
Yeah.
And one of the things that you have here is infection as a primary driver until proven otherwise. And I was also thinking whether this child was having seizures at the time of initial presentation. But,
yeah, he had seizures, Kish. Yeah. He
So
had seizures, encephalopathy, and sepsis.
Yeah, there's a confounding variable of seizure changes as well in that white matter, I think. So the scoring system will fail instantly. What if all of this diffusion change is related to only the medullary vein thrombosis, then overall people say that the outcomes are not bad. But with the overlay of seizures also contributing to the diffusion changes, you will pick up axonal degeneration in time. So if you can separate the two out, you can use the scoring system, but the scoring system will not satisfy both the realms. And then if you look at the other sequences, you take the diffusion away, then yes, you call it par echovirus or whatever you want to call it, but most likely an infective process that has driven the process. There will be some scarring. I think there's too much going on here. There will be a bit of scarring in the periventricular white matter, but can MR really prognosticate the outcome? I don't think it can, especially in the context of medullary vein thrombosis. What we don't have, luckily, is large areas of hemorrhage. And I don't know if you have any follow-up imaging on this, but clinical follow-up will be more relevant than what happens to the scans.
No, we don't have a follow-up.
And how is the child doing then at the end of time?
The child is just started to feed orally.
You would give enoxaparin here, right? Will you? You give that?
No.
These you don't give in this one.
Not good. Yeah.
Because if it is a thrombus, for any sort of thrombus, even if there is hemorrhage, one should. Is that right? Or like this is a specific contraindication?
I think from our practice here as well, and Yale has joined, we don't automatically give heparin for these patients. You treat the infection, you treat the dehydration, you treat the driver, but I don't think out in the UK you would give an enoxaparin or any other form of low molecular weight heparin. So I can tell you, based on what we know about this, the outcomes shouldn't be too bad. But what is bad and what is relative, we can't predict that. If you show that scoring again, Nihaal, you can.
So what is the logic where for all other venous thrombus in the brain, even with hemorrhage, you give enoxaparin in newborn, but not in this one? What is the reason?
Vivek, I think this one's most of them in newborns and in a situation where they are either hypoxic or in sort of septic. I think the primary process is very diffuse, and it's not just the microthrombi that is causing the overall process. Probably that might be one of the reason. But nowhere in the literature there is usage of an heparin. I think we might explore that, but we have not used, as Kish also mentioned.
Okay.
Also, this severity score does not actually tell you what happens to the clinical outcomes, right? It's just a score. Is that correct, Nihaal?
Yeah, as far as it's just a score.
All right.
Geeta, have you seen any other papers with the outcomes for the?
Yes, sir, but we didn't get much answers in those papers. So only like they were comparing the gestational age and all, and how are the outcomes in the term and preterm babies.
Overall, what we know is that with venous thrombosis, without large areas of hemorrhage, the outcomes are better than in arterial strokes.
But this being a very diffuse process as compared to usual territorial kind of venous, this one, these children don't do as well as the children with focal venous thrombosis or a sinovenous thrombosis as compared to a medullary vein thrombosis.
Lokesh, your patient also had a cyanotic heart disease with a venous thrombus. So that's more the reason to give him enoxaparin, isn't it?
No. Yeah. The cardiologists have seen this child. They said he doesn't require intervention, and they've just started him on some Indral, and they said they will follow up.
Why did you book?
Right. So yeah, no, it's just because he's got cyanotic heart disease with a clot in the brain, and just that's the reason.
Right. All right. Thanks. If there are no further comments, we'll move on to the next case. Yeah, Geeta or Debang now?
Yes. This is a 7-year-old male child with previously normal development who had come with history of seizures since last 1.5 years till now 4 to 5 seizure episodes. All are right focal motor seizures, not status, and 4 to 5 episodes till now. And also history of cognitive decline since last 6 months. There is no other associated abnormal movements. On examination, there's weakness of the right side of the face, right side of the limb with right circumductory gait. So because of the seizures, EEG was done, which was normal, and MRI was done. So
yeah, okay. We have 2 sets of MRIs, but we'll go over the first MR. Again, on top diffusion, nothing very significant in terms of restricted diffusion over there, but there are confluent abnormalities predominantly involving the white matter structures, but also the cortex in the bilateral frontal lobes, the basal ganglia, left more than the right, going down up to the temporal lobes. And there is also some degree of volume loss in the cerebral and cerebellar hemispheres. If you see on the diffusion on the right top panel, there is some restricted diffusion, and in the bilateral proximal segments of the optic nerve, the left more than right. The left is slightly more bulky. So diffuse is more like an infiltrative process extensively involving the bilateral frontal lobes going up to the left temporal lobe, bilateral basal ganglia, some areas of the internal capsule, and a degree of cerebral and cerebellar atrophy. On the FAIR sequences, again, you can appreciate the abnormalities, bilateral involvement, white and gray matter structures, some areas of rarefaction are there. And you can observe the optic nerves here. The left optic nerve is bulky, almost infiltrating over there. And on the SWA sequences, there were no areas of hemorrhage or mineralization in the involved areas. Spectroscopy was done, and on spectroscopy, there is elevated choline peaks uniformly in all the involved regions. There was a lactate peak and reduced Na, and some areas shows reduced creatine peaks, but the primary abnormalities were elevated choline peaks with the reduced Na and a lactate peak. At this time, we thought of 2 differentials, diffuse glioma or gliomatosis cerebri, which was previously known, given the areas of involvement of the white and gray matter structures and the spectroscopy findings. The other differential we thought was for an infiltrative process, possible lymphohistiocytosis. Other possibilities were encephalitis related changes, but given the MR changes did not show any restricted diffusion or cytotoxic injury, so the encephalitis or infection was slightly down on the differential. So these were the two main differentials we thought of, and a biopsy was done. Devangna?
Yes, sir. Biopsy was done. Biopsy was suggestive of diffuse parenchymal lesion with it was normal for no inflammatory or histiocytic lesions as seen. So, and MOG NMO was negative for the child. Ferritin was normal, within normal range for, and also LDH was also within slightly raised. So.
Okay.
I think the pathology report has been given wrongly.
Okay.
It is no, in the sense what Devangana said. This is the child had histiocytic inflammatory infiltrate, which is non-Langerhans cell, and one more. This one was negative. It was a the diagnosis was whether diffuse encephalitic process versus a non-Langerhans cell sort of non-Langerhans cell histiocytosis kind of thing. Langerhans cell histiocytosis markers were all negative.
Yeah, I've seen that Langerhans.
Was there any peripheral symptoms?
No peripheral symptoms at all. And we
Okay,
investigated the ferritin LDH were normal. We have asked for a PET scan. He has got it done today. We'll get the reports of the PET scan for any other area of involvement. And CSF was normal, including any viral markers. CSF is normal, acellular normal
And
protein.
protein, any, did you have bands?
No, we have just got the protein levels done, which were normal. And we have not done any bands as of now because the biopsy was not suggestive of a primary demyelinating process.
Yeah, it just okay, thank you.
Was an NMA done? NMDA done? Dr. Mankad is asked.
No, NMDA was not done. We did the MOG and NMO.
Okay. All right. I'll just show the follow-up scan and then we can go for a further discussion. So follow-up was done, I think, what was the timeline? I think after 2 weeks.
1 month, 1 month gap.
1 month. Okay, 1 month gap. Okay. So the site of biopsy is demonstrating some areocystic lesions over there and some hemorrhage, punctate foci hemorrhage. But other than that, yeah, again, similar pattern of involvement of the bilateral cerebral hemispheres, frontal regions, temporal lobes. Now you see that the right optic nerve also is slightly more bulky in comparison to the left. But otherwise, again, a diffuse process involving the white and gray matter structures. Again, no hemorrhage in the involved areas. There is some mineralization in the globus pallidus over there, but on the left side, yeah. But other than that, again, similar changes seen on the follow-up MR with some progression in the optic nerves.
Nihaal, it's a lot of progression in the contralateral cerebral hemisphere as well, right? The white matter.
Let's see. So yeah, this is
or not. I mean, it will be nice to put them next to each other, but I just thought even the temporal lobes, unless it's an artifact from how you do there's a lot more progression on the other side. We've seen that with our NMDAs and stuff, for instance. And you're right about the optic nerves. They are at the moment both sides are affected.
Yeah. So it's a non-Langerhans histiocytosis. Which histiocytosis? That is the question.
I didn't understand that.
No, that wasn't. I think there's something in that.
When you say non-LCH, you start going into entities like crystal histiocytosis and the rare things as well. But HLH is the one thing that comes to mind. But more than that, this is a post-infectious immune-mediated kind of phenomenon. You've got gliosis already at the beginning of time on the left side as well. If you look at your brain there, I think, yeah. So there is a bit of, on the T2, you can see that there is gliotic process. Even the basal ganglia looked a bit atrophic at the same time. So it looks like there would be a process going on before this time as well. And I was wondering whether the cortex on that T2 on the third picture, for instance, there might have been some hemorrhagic changes previously. Hence, I thought previous herpes or simplex and being triggering, an NMDA kind of process.
And Kisha, exactly agree, because the bilateral leucot. So basically, generally in NMDA, you do not get abnormal MRI at all. But we got caught in the past that actually you see those children with, they had HSV, and sometimes even the HSV was missed initially because they just had some seizure labeled as febrile seizure, and then presented later with a much more florid presentation. And at that point, they get the white matter disease. So the white matter disease I've mainly seen post HSV encephalitis, and that's actually the group that does quite badly. And that would also fit with the biopsy to some extent, because actually the NMDR biopsies are normally quite unremarkable, and by that point you've already cleared the herpes. So I don't know if it's but I would go back to the history and kind of check if things have changed or evolved over time. And the second thing is that generally these children have a quite significant motor deficit. I mean, is this kid, what's the clinical examination at the moment? Oh, so it has a clear hemi. Sorry, I'm now seeing the. So that would be. So I would suggest doing the NMDA antibodies in the serum and CSF, and then we could discuss if it's not too late to even give some treatment. And the bands, again, if you decide to do the CSF bands, although this is not primary demyelinating with many of those immune encephalopathy, if you do see positive bands, it just helps you a bit with making decision plans.
I think this child had a slow progressive course over the last 1.5 years. It will be so odd for NMDA. I think we must be dealing with gliomatosis cerebri. That's how they come. Gliomatosis, slowly progressive illness with the focal signs. NMDA untreated for 18 months, and the child hasn't had any acute worsening, will be so odd.
Yeah, I mean, this is kind of end stage. I mean, the child is not moving. But I agree with you that it's atypical, but wouldn't the biopsy rule out?
Yeah, the biopsy did not show any neoplastic.
Exactly. So I'm kind of thinking out of the what kind of can mimic those kind of thing. And in a way, by the time you see these changes with NMDR, the children just have gliotic changes, and it's not, I mean, you kind of nearly miss the boat sometimes with treatment. It may be a discussion whether they can benefit from treatment or not, but NMDA even untreated can kind of burn out in some ways with those horrible changes on the MRI.
Nihaal, what about secondary hemophagohistiocytosis, CNS? Does that, so not not LCH? Is that something?
Yeah, that was raised actually, and also considered.
You know my game,
Yeah, that's one of the differentials, because it is not classical for histiocytosis. Everything, it can be a secondary process as well. I had a discussion with the neuropathologist. So they said, yes, there are a lot of histiocytic infiltrates, but there are no clear markers to say, and there is no cerebellar lesion. Usually the enhancing cerebellar lesions are one of the things which will be classical for most of them.
And there is no contrast enhancement, right? There is no contrast enhancement. So which is very odd for histiocytosis,
histiocytic, primary histiocytic lesions. So that's why the pathologists put it as diffuse encephalitis versus non-Langerhans cell histiocytic process, but take a clinical decision. Now, the biggest dilemma for us is if you have to start treating as histiocytic disorder, non-Langerhans cell, you'll have to do a lot of immunomodulation. So is it really worth, or what are we dealing with?
And did we do CSF for measles antibody? Is that something worth doing?
He's not had a single jerk so far, in the sense like a myoclonus, and he has all he has is hemiparesis and speech issues. He's walking around without support.
And EEG doesn't show periodic complexes. Obviously.
No.
Because that's always, as we know, is a great mimicker in our country.
Yeah, absolutely. Yeah, absolutely.
Okay.
We lost you there, Nihaal.
Oh, we did?
No,
Can
you're
you
back.
hear me?
Nihaal, do you agree that at baseline, you already have a bit of gliosis in the left frontal area? Or am I looking wrongly into it?
Difficult to say because the white matter is completely involved over there.
Because the basal ganglia looked a bit wasted as well on the initial scan. Your screen sharing has gone, but that's okay. I mean, you can answer that question looking at whatever you're doing. I'm just thinking whether there was a previous insult which then led to all this trigger, whether it is, a panencephalitis kind of situation. And I also think that there has been progression in the white matter changes between the two scan points, which might assist or not.
We do have a patient, encephalitic. So there is no cytotoxic edema, right? Minimal, right? Is that right? Minimal cytotoxic edema, no contrast enhancement with a high choline peak, so suggestive of gliomatosis cerebri. Like one could always have a second opinion on the biopsy, which might be worth doing, or maybe the tissue. Is there something about the tissue if we don't get a good amount, or we can miss gliomatosis cerebri? Is this something? I don't know.
Because from the follow-up,
high...
the sampling seems to be correct from the follow-up, because where you see the biopsy hole, that seems to be where the business of white matter changes were. I don't think there's a sampling error.
Because if you have a herpetic lesion, NMDA, again, the history is so not suggestive, and you have no cytotoxic edema. So there's no diffusion restriction and high choline peak with no contrast enhancement.
Yeah, and if it's gliomatosis, then you have, this will be an IDH wild type. It most likely will not be a histone mutated one. Yeah, certainly worth looking at the histology of this level specimen once again for other things.
This is done at Nihaal's neuropathology, which is the national reference lab, and it was done at the center where the biopsy was done as well, but it was referred to Nihaal's neuropathology. So I spoke to the neuropathologist at Nihaal's. That's their opinion. They couldn't be very certain, but they veered towards possibility of a histiocytic process.
Ground 11. Ground 11.
Would you repeat the biopsy?
No. I wouldn't. We had appropriate site location, and we had a good tissue and good opinion. So at this point, probably not.
Okay.
Yeah, it's difficult to convince for one biopsy. I think second one is.
And nothing in the spine, as much as one can tell, right?
Yeah.
Nothing in the cervical spine.
So what is your plan, Lokesh?
That's what we are getting the PET scan. He has got it done today. We'll get the reports tomorrow. We treat according to non-angular and cell histiocytic process, and then follow.
Okay.
Yeah.
Okay. All right. Thank you. So next case, Vivek.
So he's an 8-year-old boy who had weeks history of fever and decreased oral intake with headache, disorientation, auditory hallucination. And after 5-6 days of being treated on OPD basis, he had suddenly a left focal seizure, which went into left focal status, which responded easily to phenytoin. And then he was started on antibiotic and acyclovir. His EEG did show right-sided periodic localized discharges. His CSF was normal on day 3 with no cells. And in that HSV, PCR was negative. He does have an MRI, which is so suggestive of herpes. So my question was, one, is there any other differential? And because family did not agree for a second CSF at 7th day, we gave 2 weeks of IV acyclovir. He's very well now. He's normal, back to normal cells. So just a differential and for this finding.
And the seizures only for a week, from last 1 week. Is that right?
Yeah. No previous history. And just in that acute episode, his CSF NMDA was negative, his blood MOG was negative.
All right.
So, yeah.
So just a note on the PLEDs. This is what I found in literature. The differentials are, if Dr. Vivek can just elaborate, is that a specific finding on the EEG or indicative or some of more focal process rather than?
See, PLEDs is just suggestive that there is a focal insult to the brain. So even if you have a stroke, if you have, so like we see diffusion with cytotoxic edema in the brain or diffusion images, similar corollary one can say is like PLEDs on EEG. So it's not specific for herpes.
Okay.
Is that right? Yeah, Lokesh is Lokesh there. So it's not something, it's just telling you that there is a, there is a ischemic insult to that part of the brain. I'm sorry.
All right. So I'll show the images and then get back to the discussion. Okay. So we have the diffusion on top, and the primary abnormality is in the pedicylvian region and the temporal lobe over there. There is some degree of hyperintensity on the diffusion weighted sequences. On the ADC, only the cortical regions demonstrate these low signal changes, that is cytotoxic or restricted diffusion over there. But the cortex predominantly demonstrate facilitated diffusion. The T2 weighted sequences, the cortex over there is slightly bulky, edematous, hyperintense on T2 weighted T2 sequences and the flare sequences. The satellite images again better demonstrate, but there is a slightly bulky appearance of the involved cortex, which I thought was slightly maybe not that typical for an infective process going on there. Post contrast, there is no enhancement of the abnormal area, and a choline spectroscopy, nothing points out, but slightly elevated choline, but the choline and NA peak is within normal limits. No lactates. So the concern was, is it a HSP encephalitis? Temporal lobe involvement is commonly seen in the HSP encephalitis, but I would have thought of more restricted diffusion, not so bulk. I mean, the hyperintensity is slightly more than what we see for an infective process. It usually involves the cortex, and it is not usually that swollen in appearance. So I thought, is there a possibility of a low-grade neoplasm out there as a differential for this case? A low-grade glioma or astrocytoma, given the appearance on the MR images. And now I'll open the case for discussion.
Was there any contrast enhancement?
No, there's no enhancement.
Right.
This is the top images are contrast.
Yeah.
So there's no contrast.
So that was definitely a worry about the lesion.
It is expanding the gyral folds there,
Yeah.
and it has got mass effect. It should be treated like mass until proven otherwise, of which the differential would be between a most likely a glioneuronal tumor that would be causing this kind of change. Now you can call it focal cortical dysplasia, but a focal cortical dysplasia with mass effect should be treated like an ILA3 lesion. I was trying to see if you did window on that flare, whether you could actually get a flare rim sign as well, because there seems to be some layering. And if we don't have that, then as Martin is suggesting, we're talking about low-grade tumors anyways, the MYBL1 spectrum, etc. But we're calling it tumor, if not just an FCD plus tumor, which will be an ILA3 lesion. I don't think it's a viral encephalitis, and that picture with all the various nicely colored viral encephalitic patterns rarely ever works really in practice. But I don't think it's an infection to start with. The story also is that there was something in the previous life, isn't it? It was not all that normal even before this recent.
No, he was normal. It's just a week's history of fever,
Okay.
headache.
I thought he had headaches previously or something, but no, nothing. Okay. So it's a surgical target. You should get a neurosurgeon involved early on.
Okay, sure.
All right, thank you.
So this is a 5-year-old boy who came with acute febrile illness, day 4 rash, was measles, and day 6 had severe respiratory distress, pneumonia with the apneostic breathing, and was getting encephalopathic the same day. So within 6 days of illness, he was worsening and was hence ventilated at admission. But he went into ARDS, and he did also on examination had some neurological sign, even though he was sedated for ventilation. So it was difficult to assess neurologically because as soon as he came to the hospital, he just got ventilated within few hours. But he did have a right-side eye version with left-sided weakness suggestive of a right-sided cortical predominant lesion. And there was some left focal seizure during the hospital stay in the initial part of illness. Due to affordability issues, families withdrew on day 10 of hospital stay. So yeah, the child is no more. So it's the MRI to discuss.
All right. MR, we have multifocal lesions, some of them demonstrating restricted diffusion involving the particle subcortical regions, the central regions of the brain, that is the basal ganglia, the corpus callosum, and also the supra and infratemporal regions, that is the cerebellum, also demonstrates these focal areas of abnormalities. The T2-weighted sequences, you can appreciate some areas have confluent abnormalities, especially in the superficial regions in the frontoparietal lobes. And there are, again, multifocal abnormalities involving the gray and white matter structures, involving the bilateral cerebral hemispheres, predominantly peripherally located, but can also have some areas of central involvement, especially the corpus callosum and the anterior aspect of the basal ganglia. Some of the hyperintensities demonstrate hemorrhagic foci, especially over here in the right frontal region. Yeah, and on the flares, again, similar changes as compared to the MR. Some areas have some flare hypointensities, or there, especially in the superficial regions. And on the SWS sequences, you have these areas of hemorrhage involving the bilateral frontal lobes and the parietal lobes, and the pericallosal regions have microhemorrhagic foci over there. Corpus callosum involvement is demonstrated almost on the entire aspect, some areas of sparing. The visualized cervical cord, though this is a T1-weighted sequence, did not demonstrate any edema or focal lesions. So this was the follow-up investigation-wise. Vivek, want to?
Yeah. So the testing didn't reveal anything. Whatever we could do, in
Okay.
the query was one about, is this more like acute hemorrhagic encephalitis due to measles, or this is the autoimmune process? Because we didn't give the child steroids because we were worried that this is measles in its active phase. So there was a lot of dilemma. And this corpus callosum, if you see the sagittal image, those lesions, so those were very odd. So I could find some cases of acute hemorrhagic encephalitis in measles, but not this type. This looks very, so there is a very severe vasculitic process where there's hemorrhage as well as dysmyelination, both in the cortex and in the white matter. So it was just query for future if one could give steroids here. And is there any other differential? Is this autoimmune or is this measles related only?
Can we have a look at the enhancement one more time?
Oh, there was no contrast.
No contrast, so it's just this. Okay.
Yeah.
We didn't do MOG.
The child has passed away, right?
Yeah, child passed away. Withdrew treatment.
I think this
because
is
of lungs.
yeah, your theory about a vasculitic process, which in itself could be immune, is, if you look at the cerebellar lesions, that's what they look like, right? Linear little scars everywhere. And then some areas with hemorrhagic change as well. But wow, I mean, in the context of measles, Yale, you might remember some historic cases at Gosh where the post-mortem finally revealed a demyelination, though.
Yeah, but I think having gone through these cases, I think they're likely to be HLH.
Yeah.
They had a protein of 1.5. I mean, it wasn't really as simple. So what was the CSF here?
So exact numbers, but less than 5 cells. Protein was less than 40. We had done
interesting.
We had done a ferritin in this child still, and that was normal. Not normal, 400.
Yeah, most of those
mildly raised.
Yeah, but most of these would have like not very raised ferritin. I think the kind of normal protein in the context of such a kind of diffuse, lesion, would kind of, I don't know, it doesn't feel to me particularly HLH like that, I don't know. And I think sometimes either you don't have one answer. So, you know, you may have measles with some measles in the brain and also immune to the measles. So I don't think you can really dichotomize those diagnoses always.
Or if they had an underlying immune deficiency syndrome of some sort.
Yeah. But did they not have a postmortem? Did they not at least to look if the measles was in the brain or anything else?
No. Retrovirus was negative. We did retrovirus, but no postmortem.
If you really want to dive deeper, if you still have the CSF sample, we could link you up with the metagenomics people if they found something else. But I don't know how easy it is to transfer samples across.
Yeah. And also, Kishla, if you think about a few of the HLH that we've seen with the finding ones, you don't pick it up on the CSF, you pick it up in the brain. So,
right.
So the utility sometimes in the CSF is not, because a lot of the time those viruses kind of hide somewhere in the brain that you can't just get into, but also, particularly if the CSF is so clean, I doubt that we would find it in the CSF on its own.
So Yale, if you have a CNS HLH in whatever situation, so you should have some cells and high protein. Is that how it should be? So, but
no, not always, but
usually,
I feel like when we see that degree of involvement, they normally have a bit of a raised protein.
Okay, and oligoclonal bands, would they have oligoclonal
variable? That's also depend what you see a lot of the time in these patients. Again, that's why I was asking about enhancement, is that you tend to have enhancement. So you would have open of the blood-brain barrier. So they may even have not necessarily type 2 bands, but more type 3 bands. So it's serum and CSF and more than CSF. And it's difficult. I think your case is very difficult, you know, and I think we just need to take into account that there could be more than one thing causing this devastating thing. And
yeah, I was also trying to read that middle cerebral artery on the 5th image. I don't know if you have any other form of vascular imaging, but that does look very serrated out, for want of a better vascular image. Seems to have multifocal infarcts at this stage, which could be vasculitic, but...
And do you think, Kish, this is primary or secondary to this? So
I think this would be secondary to the measles and whatever other drivers.
Yeah, exactly.
That doesn't, Nihaal will agree that MCA caliber doesn't look good at all, even on that one picture we have.
Yeah, on both sides, I guess.
Yeah. Ugumba is talking about AHLE. I think, but from description, this is an acute hemorrhagic leukoen. I think by description it works, but there might be a driver to the whole idea of AHLE as well in this particular case, and it still would be a post-viral phenomenon in that respect. But these are infarcts on the diffusion until proven otherwise, vasculitic infarcts in the context of, I think, abnormal blood vessels as far as we can tell.
Dr. Vivek, anything else?
No.
How easy or difficult, Vivek, is it to get any postmortem done, especially when such an open, unknown case?
So I don't work in an academic institute, right? I work in a private hospital. So in a private hospital, to get postmortem is not easy.
Yeah. And how many of you have seen mortality from measles? Just because I don't have a handle on that. Outside the context of SSPE, because you wouldn't label this as SSPE, right?
Not SS. So if acute measles, so over the years, maybe if one sees 10, maybe in one patient. So for me, maybe I've seen acute CNS involvement in measles, maybe 5-6 cases, and 2 have died and rest left with severe morbidity if there is CNS involvement. But that's part of many more measles which we see. So rarely you get CNS involvement, but if you do get it, it's not good news.
If there's any experience from other countries of measles, please share. Feel free to share in the chat, I think.
Yeah, all right. Yeah, we'll see the chat and we'll move on to the next case. There's no other time. So yeah, if anyone has any experience, you can put it off in the chat.
So this is a 6-year-old girl who was born to elderly parents, IVF baby, donor egg, because that might be important as context of the differential, who was well with normal development, except for significantly being undernourished. At 6 years, she was weighing 15 kg, but was a normal child till 11 months back when she had a episode of sudden onset vision loss for 24 hours, which recovered by itself. And parents didn't take it much further. And she was well for next 10 months. So just 2-3 months back, she became unwell again suddenly, 2 months back with right focal seizure leading to focal status. At that time, my MRI was done, which we are going to discuss. And she was diagnosed and she recovered. Within few days, she was managed with anti-seizure medicines. So this is around 2 months back. And then at that time, she had this MRI from in another hospital, diagnosed as CNS vasculitis, given methylpred pulse and oral steroid and on a weaning dose. CT angio was normal and she was sent home. And then just 3 weeks back, she again had right focal seizures through the night with high-grade fever. And then she came to our hospital just 2-3 weeks back. But we didn't repeat the MRI. We already had this MRI from 2 months back. And we can discuss it then. Few of the echo was normal as part of the vasculitic workup in the previous hospital. This blood lactate we did this time, which was 12. And now she's recovered. She's gone home again after 7 days of hospital stay, and a baseline lactate still is 4 with a normal pH. Otherwise, the CSF was normal with no cells and proteins were normal.
So this MR is 2 months back. Is that right, okay?
Yeah, so around mid-December.
Yeah. So there are tiny ischemic areas in the parietal lobes and occipital lobes, more on the left than the right. Other than the posterior ischemic changes, I do not find any abnormalities, especially in the basal ganglia or the frontal and temporal cortex lobes. On the FLAIR images, I was trying to look for any gliosis or volume loss, which could be suggestive of repeated insults. I think they're suspecting something like MELAS, given the recurrent ischemia and the concern, the high lactate.
Yeah.
Okay, so on the SWA sequences, again, we didn't have any abnormalities over there. And post-contrast, they're mentioned as vasculitis, but I could not appreciate any significant enhancement, and there was no, at least there was no angiography or visual imaging on the MR determined as vasculitis specifically, but yeah, they look like ischemic lesions, small vessel ischemic lesions. So yeah, I think the question is it a possibility of MELAS? That's all open the case for. CT angio was normal, just this the angio was done after the MR.
Yeah.
And the MR scan explains the visual loss, isn't it?
So there was no vision. No, this time there was no vision loss. This vision loss was 11 months back, which recovered.
Okay. Yeah.
So that's why but there's no gliosis from that time.
At least the diffusion and FLAIR sequences, they correspond to the I think same event, because the areas of the high restricted diffusion demonstrate same hyperintensity on the FLAIR. So I was unable to appreciate a mismatch of the diffusion and the FLAIR sequences to see if there are any old lesions.
So could this be MELAS sort of?
I don't think we can exclude MELAS here, but it's a differential. Bilateral changes, and if you talk about MELAS, you're probably going to put the whole mitochondrial spectrum in there, Paul G, etc., for instance. But just going back to the history, I am wondering what happened to the optic nerve side of things, and then.
And MOG was negative. We did MOG and NMO. negative.
Vision acute loss of 24 hours, 1 year back and recovered. Recovered within 24 hours, Dr. Ek, or?
Yeah, they're saying within 24 hours and her vision is normal.
I think the obvious questions people are going to ask is about spectroscopy and things like that. But
yeah,
I
at
think
the time they didn't suspect, so
yeah,
MRS
exactly.
not done, and this time she recovered within few days. So this time she had very high procalcitonin, so high fever for 5 days. So some sort of a viral process or a bacterial process culture was negative, which triggered her seizures again, and she deteriorated, and then she recovered again. Initial admission pH was 7.1 with a lactate of 12, and she went home on a normal pH 7.4 with a lactate of 4. Normal is less than 2 in our hospital.
I mean, yeah, I mean, it's in the differential for the workup for this stroke-like event, isn't it? But why just mail us, and we'll probably end up doing all the mitochondrial genomes, right?
Sugars. So mentioned metabolic stroke. So what other metabolic stroke in this area, not in the globus, but in this area?
Prabjot might be alluding to things like FOLR1 and all that, the unusual spectrum that can also present with stroke-like events. But I don't think we have any more handle on this than what you have already mentioned.
Okay.
Is that right, Nihaal?
Yeah. Will we do a follow-up now, or just leave it as that, or directly go for genetics?
So I've sent just for mailers. So
Okay.
so it's a cheaper test, just few thousand rupees, and you just test for 3 common variants, which pick up 80% of the patients, 80%. I just did that first.
Let us know if it's positive.
Yeah.
At least that's useful.
Hi,
Sure.
everybody. This is Prabjot this side. I just wanted to know, I think Dr. Sir mentioned about there being metabolic acidosis along with elevated lactates. Right, Dr. Vivek? You said
Yeah, initially because of sepsis, I thought, but that was more like, she was in early septic shock, high procalcitonin. So that must have caused it.
Okay. So I was just thinking along those lines, certain other organic acidurias can also present with only metabolic strokes, and then they can have acidosis along with elevated lactate. So that is what I was thinking about when I thought about metabolic strokes.
But do they not present those metabolic strokes with basal ganglia involvement rather than
They have basal ganglia involvement and can have cortical involvement, but I agree that isolated cortical involvement may be unlikely. But that is just one more thought. Maybe you can look up. And the other thing which I find odd for organic acidemia is definitely sudden vision loss that should recover. So that was just a thought.
Sure. Thanks.
All right. Thanks, Dr. And Dr. Ek, please let us know if you get anything on the mail last panel.
Sure.
The next case from Belgaum, Tanuja, if you're there.
So here we have a 1 month, 10-day-old female baby, firstborn of non-consanguineous marriage with a normal birth history. The child had irritability and inconsolable cry for 1 week and 2 to 3 episodes of seizures per day from the 2nd day of illness. There is no history of fever being associated with this illness. So the child was admitted and evaluated for the same. For refractory seizures, child was also ventilated for 1 day. CSF analysis was done at this time and it was normal. First imaging was done, which will be shown now.
Yeah. What was the age? Is that 40 days? The child?
Yes, sir.
1
1
month,
month, 40-day-old baby.
All right. Geeta is asking seizure semiology before we go to
The seizure semiology was actually not an observed event. So the parents could not tell much other than just uprolling of eyes, because most of the seizures occurred in hospital. So in the ICU, the parents were not allowed. But the history which we got was that there were some 2 to 3 episodes of seizure with uprolling of eyes.
Yeah, Dr. Kamte, you want to add anything? Okay, so we'll have a look at the images. So these are taken from the video, so they are slightly pixelated. So they are symmetrical areas of restricted diffusion involving the corticospinal tracts, the perirhinal regions, the internal capsules over there, some areas of thalami, the brainstem, the mammillary bodies, the optic tracts, and also the cerebellum. So the major findings are in the diffusion-weighted sequences, which demonstrate corresponding changes on the T2-weighted sequences and some hypointensities on the T1-weighted sequences. There was some posterior subdural hemorrhage, but this is probably likely due to some iatrogenic process rather than something hematological. The visualized cord, at least the cervical cord, did not demonstrate any edematous changes of focal lesions. At this point, I think the diagnosis, the working diagnosis was maple syrup urine disease, given the findings on the MRI. Yeah, Tanuja.
Yes, sir. So we suspected MSUD. So at that point, the child was referred to us. And on admission, irritability and altered sensorium persisted. There were no further seizures after admission at our hospital. There was no dysmorphism. Child was found to have dystonic quadriparesis. So suspecting MSUD, we sent for TMS, UHPLC amino acid level and started on MSUD specific diet. But we found that TMS levels, amino acid levels were normal, and MSUD diet was stopped. So at this point, we reviewed literature and we found that PIGA gene mutation can also have initial neuroimaging similar to MSUD. So we went ahead with exome sequencing and did a repeat MRI. So the second MRI will be shown now.
Oh no, it's fine. It's just a little time.
All right.
I do actually.
Now, so repeat MRI 11 days later. There is significant progression, but now there is development of cystic changes or cavitary changes involving the frontal white matter, parietal white matter. The periinsular regions demonstrate these areas of cavitation or cystic changes. Basal ganglia also demonstrate now areas of necrosis and some area and ischemia. The cerebellar changes somewhat have improved
No, I'm
in
going to call them in a
comparison to
second. Can I? Do you mind? It's yesterday afternoon, so it doesn't need to be soaked.
Yeah, so cerebellar changes have slightly improved in comparison to the previous study, but we have seen, as you can see, there is significant progression in supratentorial areas, significant cavitation, ischemia, and necrosis, confluent white matter abnormalities. So Tanuja, yeah, after the imaging.
So we just about the other investigations. So CSF analysis was normal. Routine investigations, including the complete hemogram, LFT, RFT, electrolytes were normal. EEG showed hemi-generalized sharp wave burst, left more than right. And after repeat imaging, we suspected mitochondrial Leigh disease or molybdenum cofactor deficiency and vanishing white matter. We kept these differentials. Child was started on coenzyme Q, riboflavin, thymine, and biotin. We got the reports of the genetic tests. Mitochondrial genome sequencing was negative, and clinical exome showed the genes which we have displayed, that is EIF2B3, EPRS1, TRAPC12, but all were variants of unknown significance, and they had autosomal recessive pattern of inheritance. They were heterozygous. So we wanted to know what can be the other differentials in this case.
As I think someone has pointed out, mitochondrial, I would still think mitochondrial, Dr. Mankad, biotin, thymine responsive, though I've not seen significant such extensive cystic changes or cavity changes.
I think the initial involvement of the brain
that looks so much like MSUD.
It does mimic MSUD, but it was metabolically demanding structures of the brain. So mitochondrial can definitely be, should be definitely be considered in that respect. And the way it evolves and unfolds from there. But the question nowadays, if we say mitochondrial, the question is which mitochondrial, and that's where the discussion should be. Did someone say pigopathy in the middle of all this discussion, like a pig or something?
Yeah.
Why did that come up?
So on reviewing literature, we just found that some PIGA gene mutations, they can have imaging findings which can mimic MSUD.
But they're more they're more linear
yeah.
along the pituitary tracts rather than the more here it is more confluent. Do you agree, Dr. Mukher? They only involve the pituitary tracts, the plics, I think, the plics and the ventral brainstems.
Okay,
yeah,
sir.
I mean, there's not much known about the imaging of pigopathies. In fact, we are at the moment we've put a call out for people who might have confirmed pig cases, and we are trying to put it together. But in this respect, you have an open situation. And in terms of the genetics that you did, was it a whole exome sequencing, or you did a clinical exome, right?
Yes, sir. We did mitochondrial genome plus clinical exome.
Right. Okay. So it looks like Nihaal has the answer to this case, so he can proceed.
No, I don't. That's thinking mitochondrial, but yeah.
Would the next step then be to do a muscle biopsy or something? How will you confirm this?
So we are planning whole exome or whole genome sequencing next, but we just wanted to know what else we can think of at this point and how to proceed.
The organic aciduria are completely ruled out, right?
Yes, sir.
Yes.
Nihaal, we should discuss this case at the National Neurogenetics meeting at the UK as well, which is happening on the 3rd of February, if any of you want to join.
Okay.
If other people have seen similar kind of features. But I think most of the people will end up calling this mitochondrial and proven otherwise, right?
Yeah, the only question is what line of investigation, whole exome, whole genome, or biopsy as the option. The question of cerebral venous thrombosis.
I don't think it explains
I
everything.
don't think so. Yeah.
Okay, we shall have a little more think about this case.
Yeah.
Okay.
Yeah, Tanuja, if you get anything on the whole exome and genome, please let us know. But yeah, we'll try to discuss it next week in the Neurogenetics meeting.
Okay, sir. Thank you.
Thank you.
Thank you. All right, next case, Geeta.
Yes, this child is a 6-year-old female child with normal development and previously healthy, presented to us with respiratory issues for 5 days in the form of cough, cold, and like breathing difficulty. So initially managed with FSNC support and then requiring the ventilatory support also because of the increasing respiratory issues. And further, she developed secondary PAH, pleural effusion, and we have to escalate the therapy in the form of iron and oscillatory ventilation also. Child had persistent respiratory acidosis, hypoxemia, developed ARDS, hence started on ECMO, which was a veno-venous type, almost for 11 days, and then slowly stepped down to conventional and presently on the tracheostomy. So these are the respiratory issues. Neurological issues wise, only there was one episode of seizure on day 5 of illness, which was GTCS type. And on examination, this child has significant pyramidal signs, spasticity with brisk reflexes, and also there are certain involuntary movements in the form of perioral twitchings, occasional intermittent tonic posturings are there. So we want to know, like, one CT is being done and 2 MRIs are done for this child. So what can be the cause of all these changes we wanted to know?
Okay, so CT was done at day.
Almost the 3rd week into the illness, respiratory illness.
And how long after the cardiac issues?
Almost 10 days.
All right. Okay. So there is some degree of volume loss over there, but I could not appreciate any focal edematous changes, especially in the deep gray nuclei. Basically, and the thalami did not demonstrate any hypodensities, possibly in the temporal lobes, but difficult to comment on the CT. Yeah, so I'm just seeing cerebral atrophy, cerebral and some degree of Burman atrophy over there. And the MRI was done after how many days, Geeta, from the CT?
About within a week, sir.
Okay. So again, I mean, you can see there is progression in the volume loss. And now you have some areas of subtle hyperintensity is predominantly involving the thalami, more clearly involving the pulvinar thalamic nuclei on both sides. The temporal lobes also, the middle temporal lobes and the amygdala demonstrate hyperintensities, which are more clearly visible on the flare sequences. So here you can appreciate that the bilateral temporal lobes are edematous. The bilateral thalami are edematous. Some areas of the cortex demonstrate flare hyperintensities, especially in the frontal and perisylvian region. Cerebellum did not demonstrate any signal changes, but there is again progression in the volume changes in comparison to the CT. On the SWS sequences, there were multiple microhemorrhagic foci in the pericallosal region and the corpus callosum. Post contrast, we did not appreciate any enhancement. A follow-up was done at 8 days later, there is again you have these areas of hyperintense changes in the thalami, the bilateral temporal lobes. They do not demonstrate flow signals on the ADC sequences possible. And also on the initial images, there was no restricted diffusion. So here again, the T2 and the flare images, you have these changes in bilateral thalami predominantly, and also the temporal lobes. There is some progression in the volume changes again in comparison to the previous MR. Yeah, and again, similar changes of the microhemorrhagic foci in the pericallosal region and the corpus callosum. So this is comparison of the two MRIs, the flare sequences, 19th and 27th, almost similar changes involving the deep gray nuclei and the temporal lobes. Possibly some reduction in the temporal lobes over there in terms of edema. The pulvinar edematous changes are slightly more prominent over there, but yeah, very negligible changes. So the differentials we thought was one was the hypotensive injury given that the cardiac issues. The other was, is it a viral meningoencephalitis causing these changes in the temporal lobes and the thalamus? And given the movement disorders, is there a possibility of to consider an autoimmune disorder such as NMDAR for this child? So yeah, these were the differences which we thought of, and I'll open the case for the panelists to discuss.
Dr. Nihaal, this is Dr. Anupama.
Yeah.
There is no cardiac issues with this child. This child had a
Okay.
secondary pulmonary hypertension, which happens in any child with a severe ARDS.
Okay.
There is no cardiac dysfunction in this child. There is severe ARDS, severe hypoxemia, for which the child had to be escalated to VV ECMO. But on ECMO, the child was not on any hemodynamic support, neither there was a cardiac dysfunction with the child.
Okay, and just the CSF, I mean, we got, I think, bacterial, fungal, and viral.
ESF, we haven't done on ECMO.
Okay.
Post ECMO, no, we haven't done any CSF on this child.
Was this the case with adenovirus?
Yes, yes. This is adenoviral. It's an adenoviral with a secondary bacterial infection and a probable fungal, because the fungal antigen came positive for her.
Okay. The question here was, is it a para-infectious process, autoimmune process, or related to the respiratory issues?
Like more of a whether hypoxia or a para-infectious process, like to differentiate.
Can we just look at that history again, Nihaal? So when you start people on ECMO, you give them anticoagulation, is that right?
Yes, she was an anticoagulation.
So the micro hemorrhages could be related to that in itself. Otherwise, there's not much in the brain. You talked about a bit of volume loss, and I'm not even sure if those changes in the thalamic nuclei are real, because they, the thalamus is not one structure; it's got multiple nuclei. So the slight volume loss is probably real. Could be related to steroids, hypoxemia. long-term hospitalization or even the virus per se. I don't know what is the handle here from imaging. And I think that thing in the brainstem is an artifact, isn't it? The fourth picture.
Yeah, that's not it.
Yeah.
But later on, the child developed some movement issues. Is that right, Geeta? That was slightly
Yes,
unusual for
movement issues like perioral and also posturings were there, but she was in. It can be because on the long sedation also she was on morphine and all. So
Yeah,
here,
but
yes,
not particularly dystonia. Talk about spasticity with brisk reflexes,
yes.
tonic posturing, but that would come from long tracts, right? It wouldn't come from the thalami per se.
So we didn't do any CSF or any autoimmune workup for this child. So like, do we need to do, because almost 20 days, 20 to 25 days into the illness now, she is recovering. So to counsel the family and all.
Not from an imaging perspective, I don't think so. The pulvinar often stands out when you're windowed the flare so strongly, isn't that right, Nihaal?
it does, but I don't think I went to it that much. Yeah.
It yeah, it hasn't changed in the 19th to 27th overall.
No, it hasn't changed.
Okay. So what we are saying is we are not seeing any obvious imaging manifestations of a post-infectious or para-infectious phenomena, apart from volume loss. But that volume loss can be explained by so many factors here. They have not been well from a respiratory point of view, and they have been hospitalized and other things. ECMO could explain the microhemorrhages in the brain.
Yeah. So it suggests that nothing on the, at least the imaging doesn't.
No, I mean, nothing, no angle for a
direct,
workup, but
yeah,
many of
yeah.
these, if you still want to do an autoimmune workup, you're welcome to, but I don't think the imaging is going to guide you in that process.
All right, Geeta, anything else?
Nothing, sir. Thank you.
All right, thank you. To our next case, Sahil or Ramani?
Yes, sir.
Yes.
So this is a 14-month-old boy born of second issue of non-consanguineously married parents. So he presented to us with global developmental delay, and he had this rash. The peculiar pattern of the rash initially, no very specific on the face, on trunk, on hands, on limbs. So it was initially red, followed by changing blue, then blackish discoloration, followed by no rash at all. And this whole cycle used to continue for around 15 days. So such an episode of cyclic events, he used to get rashes all over the body periodically, and they were frequently changing sites over a period of 15 days. So in a month, there were like 1 to 2 such events used to occur, not related to any other like dependent parts of areas. So other thing was that he had microcephaly on examination. He had facial dysmorphism, right-sided cryptorchidism, hypotonia with deep tendon reflexes. So as a part of global developmental delay, we did his fundus examination, which showed bilateral tortuous vessels in both of the eyes. And right eye showed some gliotic changes. And BERA, which we had done, it showed bilateral severe sensorineural neural hearing loss. And along with that, so possibility we thought of either a mitochondrial disorder or a vasculitis in this child. We went ahead with the MRI.
All right. Okay.
Yes, sir.
Sahil, they're asking for the clinical images, but I don't think we had permission, right?
Yes, sir. Yes, no.
All right. Okay. All right. What was the age again? Sorry, 14 months. Okay.
14 months, sir.
Yeah. So we have some white matter changes in the frontal lobe and also the periventricular regions. But the predominant changes are these patchy areas of involvement in the bilateral basal ganglia. There's also some degree of volume loss, especially in the frontal lobes and the anterior temporal lobes. Coming down to the posterior fossa, there is again cerebellar white matter demonstrates these patchy hyperintensities, which show some areas show areas of rarefaction, especially in the middle cerebellar peduncles. Corpus callosum is slightly thinned out. Midbrain is also demonstrating some areas of reduced volume over there. Diffusion various sequences. Nothing on the basal ganglia changes, but they were foci of restricted diffusion in the cerebellar abnormalities. The established sequences wasn't sure if these are punctate foci of abnormalities in the bilateral basal ganglia and thalamus, but specifically nothing on the cerebellar lesions. And on spectroscopy, in the basal ganglia lesion, there was a lactate peak, and the rest of the peaks were normal for age. Given the imaging findings and the rash-like picture, we were thinking of possibility of ethylmalonic encephalopathy, which usually presents with these petechial rashes and this patchy involvement of the basal ganglia. And going down in the literature, more looking closely at the pattern of rash, they are known to have these diffuse spontaneous relapsing petechial rash-like changes. They can also have these orthostatic acrocyanosis. I don't know if that was evaluated or not. And again, these are vascular lesions in inborn errors or of metabolism, and ethylmalonic encephalopathy usually have these petechial rashes. So we're thinking of ethylmalonic encephalopathy as a primary diagnosis, and I'll open the case for any other further comments and discussions.
Yes, sir. So the clinical exam was sent, whole exam was sent, sir, this child, and it turned out to be ethylmalonic encephalopathy. Yeah.
So this rash is actually quite typical for ethylmalonic aciduria. Sometimes it can appear as even cyanosis kind of a picture, or some petechial kind of pictures also.
Okay. Mm-hmm.
Yeah, I think the mention of orthostatic acrocyanosis, is that
yeah, that's what. It looks
yeah.
like very odd that a child is having cyanosis, no clubbing, no ASD, but it we had one case which ultimately turned out to be ethylmalonic aciduria. So petechial rashes, cyanotic, cyanosis, ectocyanosis kind of a picture, we should think of this entity.
It's still mitochondrial, right, Prabjot?
Yeah, it is.
It does come in the group, yeah.
And would a clinical exam pick it up?
Should pick it up.
Should pick it up, okay. But yeah, great. At least there's closure on this case. How you treat it?
Combined treatment with oral metronidazole.
Yeah, oral metronidazole and N-acetylcysteine has been given, sir, in literature, but the curative is the liver transplant. Yeah, it is given, yes.
Yeah.
All right, okay. That's interesting. Metronidazole, okay.
All right. Thanks, Sahil. Thanks, Dr.
Thank you, sir.
All right, to our next guest, Dr. Vivek. We lost him.
Yeah, 13-month-old baby who normal birth, no neonatal issues, and was normal till 8-month age, and then she regressed till 8-month age. She did have some motor delay, but otherwise cognitively she was doing well. But in the last 6 months, she has regressed in the sense she has lost her whatever achieved motor milestones. Where she was standing before, now she's barely able to sit for some time. She does have central hypotonia with preserved reflexes. Mother was more worried about the mild ptosis, which she has developed over the last few months. And surprisingly, she also had history of oculogyria, which she was very clear that she would look to one side and will force herself to bring the eyes to the midline, which she couldn't. And then that made me suspect. She didn't say whether if she had decreased facial expression as well. At that stage, I didn't have an MRI image. So at that stage, my differential was more like a neurotransmitter disorders because of a ptosis and maybe slightly decreased facial expression. It's only after the MRI that I had done the opthal evaluation and other things. So this is her at 13 months. She's hypotonic. She's a bit unsteady. My mom said that she used to cruise along and now she cannot do that, just able to sit. That's how. So
did the child have a large head?
So head size was appropriate for age. It's
Okay.
not that large.
Okay.
And the ptosis is not that clear here, but the first thing which struck me was the ptosis when she entered. My mother was worried about it as well. So my differentials were different, sort of a bit different than what it was after the MRI.
All right. Yeah. So yeah, these are the MR images, and we have this diffuse myelination abnormality, hypomyelinating pattern in the cerebral hemispheres on both sides, and the basal ganglia demonstrate these hyperintense changes. The thalami, especially the ventrolateral thalami, are dark on the T2 weighted sequences. Cerebellum white matter is possibly slightly delayed, but nothing very nothing standing out in particular over there. On the T1 weighted sequences, the corresponding basic ganglia changes are slight hypointensities, also involving the external capsule. No abnormal mineralization or hemorrhage, no diffusion changes, reduction in the size of the corpus callosum. The posterior fossa structures demonstrate normal volume, and on spectroscopy, no diagnostic peaks over there. So it's primarily a hypomyelinating disorder, diffuse myelination abnormality with deep brain nuclei changes in the form of hyperintense basal ganglia, dark thalami, and we are thinking of gangliosidosis based on the imaging alone. But I think there are some clinical features which might support the diagnosis of a lysosomal disorder with gangliosidosis as the primary differential. Which gangliosidosis? I think the clinical handles should help out rather than imaging, if I'm not mistaken.
Sometimes it's not possible clinically, even though GM1 will have more core spatial features, and sometimes they have a very large this Mongolian spot on the back, which she doesn't have. Otherwise, it can be difficult.
I think on imaging, it's, I mean, it will be difficult to differentiate, if I'm not mistaken. Tomankar, anything to add on?
No, I think you approached it quite well from an imaging perspective. That first of all, we should pick up the hypomyelination, then we should pick up the thalamic signal, and then the basal ganglia should narrow it down. GM1 can also give you a bit of mineralization in time in the pallidal nuclei. I think you can see a little bit of that on the T2. But otherwise, not more can be said as to which type and subtype and all that. The spinal cord is involved here, isn't it? It's an interesting.
Yeah, example. It is. Yeah, it is. It is. Yeah.
That's the lesser known fact with the GM1s, if you think about it.
So GM1 or GM2 or GM1?
It's in GMs in total.
GM, right. Oh.
You should collect these cases because we often think about spinal cord involvement with mitochondrial entities, but not much has been said about spinal cords with this kind of entity, with lysosomes. We can get the root enhancement and all that, but this is intramedullary. Interesting. I don't know what your spectroscopy is showing, by the way, if anything.
No, I don't think anything particular. Yeah.
So what was the final answer here?
So enzyme studies sent. So just saw the child yesterday.
Okay. All right. All right. So we have one follow-up which was discussed on last month. Quickly, if Ramani or Sahil are there, they can. Okay. So yeah, this was discussed last month, and this was a 7-month-old child, came with severe global developmental delay, had severe hypotonia, some decreased power in both upper and lower limbs. There was CNS and PNS involvement, no facial dysmorphism. Clinically, they were thinking of genetic disorders involving the CNS and the PNS. So EMG and NCV were normal, and the causes were favoring more of a central hypotonia picture. So this was the imaging. What we found was diffuse myelination abnormality, especially white matters on the periventricular and deep white matter. But we also found that there was some tortuosity of the vessels. If you can observe on both sides over there. On the T1s, again, corresponding changes to what we see on the T2 weighted sequences, some degree of volume loss in the cerebellum and also in the frontal lobes. There were symmetrical areas of restricted diffusion in the bilateral globus pallidus, posterior plagiocephaly, some volume loss of the brainstem or hypoplasia of the brainstem, cerebral atrophy. Again, on the MIP images, you can appreciate the tortuosity of the vessels. Spectroscopy did not demonstrate anything significant. Small lactate peak, but that is not. I don't think that is significant given the depth of the peak. The whole exome sequencing was done. We had 2 genes. SPINacademics was said to be pathogenic, but on at least the imaging doesn't match. They usually have only cerebellar atrophy, but the other supratentorial findings are not present. So thinking of a possibility of Menkes disease, I don't know if we have someone from Pune who want to confirm the diagnosis of any parental testing was done.
Sorry, Nihaal, did you say the SP-tan is a Menkes?
No.
The SP-tan
we had
would
2
be
genes.
here, no? The manifestations are standard. I think the imaging would be supportive of it, right?
Yeah, the cerebellar volume loss, yes. The basic ganglia changes and the tortuosity of the vessel.
Are these pictures of the same case? No.
No, this is from literature.
Show us the pictures of the actual case. It's quite an early presentation, yeah. Can we radiologically discard Menkes?
I don't think so.
That would help them if we did that. But the blood vessels are abnormal, right?
Yeah.
Yeah. Okay. So we can't. I think Menkes, you don't get much of a cerebellar atrophy though.
So parental test. I mean, they're not going ahead with parental testing. Parents are not affordable.
Nothing on the hair and other things.
No.
Well, if it is Menkes, then a repeat scan, if nothing else, could help in terms of establishing what happens next.
But we would have got a copper level, right? Ceruloplasmin and copper. Was that normal or low?
I think Pune has left us, so I don't have answers for that. I'll find out and maybe we'll update that on the next session.
Sure.
Was there hepatomegaly? No hepatomegaly. Yeah. All right. I'll check with them and get back in the next session. Okay, that's the end of our session. So thanks again, everyone, for joining in. Our next session will be on the 10th, and kindly submit your cases by 8th of February to either me or Gita.
Thank you.